العافية. اتفضلي يا
والله
دلال.
طبعا يا هو زي ما قلنا حنتكلم عن اوبتيمست ترايل الليله. انا دلال. انا شغاله هسي في ستولري تشيلدرنز هوسبيتال في ادمنتون في البرتا. حتلقوا في ناس كتار هنا في الجروب ده يا مروا على ستولري او اشتغلوا او لسه شغالين في ستولري. ما عندي اي conflicts to disclose. دي اليونت حقتنا الجديده يا محمد، انت ما شفتها دي على الشمال. ودي ادمنتون طبعا بارده جدا جدا يعني، فما ممكن يا عبد الله نقعد في الحديقه زي ما انت هسه قاعد في الحديقه. طبعا في ادمنتون 10 months out of the year بيكون شكلها عامل كده، لكن برضه احسن من وينيبيج. فيلا الاوبتيمست ترايل كان الاوبجيكتيف بتاع الترايل دي is to examine the effect of selective application of MIST at a low FiO2 threshold on the survival without BPD. It was an RCT, it was a large RCT. It was performed in 33 sites in 11 different countries. It ran from 2011 to 2020. It was published just in December في JAMA. Why did I pick Optimist for today? And I was interested in the study. I know Edmonton is one of the sites that participated, but other than the study protocol, really, I didn't know much about it. So I was interested in the results. It is large, it's multi-center. There is paucity of literature prior to this paper on the comparison between MIST and CPAP only. There's also paucity of RCTs in administration of surfactant at lower FiO2 thresholds. So most of the surfactant administration trials that we have up to this point are using FiO2 thresholds of 40% or above. BPD continues to be a common morbidity for our patients. And MIST seems to be gaining popularity in units throughout the country. فأنا قلت أجيب هنا شوية وأسأل يعني الجروب منو بيستعمل ميست في اليونت حقتهم أو يعني minimally invasive surfactant administration.
أول حسي يا دلال، المس دي فرقة شنو من ليزا ولا بس فرق بتاع أسامي؟
هي يعني شوف ما ميست is general صح، يعني هو minimally invasive surfactant therapy، وممكن تكون بأي طريقة من الطرق بتاعت surfactant administration without intubation. لكن في this trial specifically هم بيتكلموا عن mist with thin catheter introduction into the trachea. لكن والله ما أعرف، يمكن زول تاني عنده فكرة أحسن إنه إذا في فرق بيناتهم يعني. لكن
هو الفرق بس بيكون يا دلال في الليسا والميست في the way you administer surfactant. هي يعني مثلا بيستخدموا ماجين 4 steps وحدين لا directly distilled through مثلا بس catheter and while you withdraw laryngoscope وحدين you keep the laryngoscope. فهي دي difference بس. وحدين بيستخدموا مثلا thin catheter وحدين بيستخدموا vascular catheter that is more rigid. هي بس الفرق كده بس الconcept is the same. الconcept ايوه. احنا استخدمنا صراحه الليست في المستشفى العسكري في الرياض، بدينا نستخدمها وتجيت بوبولاريتي شويه، لكن الناس ما كانوا كوايت يعني enthusiastic to use it لانه هي شويه الطريقه بتاعتها difficult. يعني مثلا 1 ولا 2 جاء ادوا 2 babies مثلا ليسا، بعدين the baby vomited some of the surfactant او كده، فخلاص بيجوا they are not very enthusiastic to continue this. هي عايزه يعني مين but we were using
صح. هو regurgitation بتاعت السرفاكتنت بتحصل اكثر من بالانتوبيشن عشان ما في PPV صح. وطيب في gestational ages معينه يا وفاء بتستعملوها فيها ولا في guidance in terms of gestational age؟
احنا we prefer to use those below 30 weeks عشان الكميه بتاعت السرفاكتنت بتكون less لانه الويت is less، لانه the bigger the baby the more surfactant you need. عشان تدي 4 ml per kilo in a 2 kilo baby you need مثلا 8 ml. It will take time to administer. لكن لو كان وزنه 1.5 you will use only small amount and success بيكون better. This is what we noted below 32 weeks usually.
وطيب في gestational age where you wouldn't أقل من 25 ولا أقل من 24 ولا حاجة زي دي ولا لا؟
usually أيوة إحنا below 28 weeks يعني we don't prefer ندي ليسا. Usually most of them will be intubated يعني.
Okay, between 28 and 32 type place. That's good to know. Any other centers that use it?
ما قاعدين نستعملها.
لا.
حد حسي افتكر have been approved for ليسا، لكن مسات ما بتاع الكاتيتر عشان تبايد بتاع big process. لكن so far الناس اللي شغالين فيها يا دوب getting used to ensure خليك انك تجيب ليزا.
ايوه طبعا في ادمنتون يمكن الكمفورت ذاته جمع الاوبتيمست ترايل، لانه بقى في طبعا يعني عدد من الناس they got trained عشان الانرولمنت بتاعت الستدي، وبعد كده بدوا يعملوا تريننج لناس ثانيين. فالحصل يا محمد بعد ما انت مشيت انه يعني بدوا تخيلوا بالجستيشن age of 30 weeks and above، بعد كده نزلوا له 28 weeks وهسه نزلوا له 26 weeks، لكن most of the babies that get it are above 28 weeks at this point.
انا بذكر واحد الاوبتيمست دي كان انا ادمست one of the doses لواحد من الشوفه لما كنت خلال الار تي روتيشن بتاعتي. ما بذكر يا ربي هي كانت شام دوز ولا جد؟
لا ما
لكن بتذكر
لكن حتكون جد، لانه البيشنتس في الكنترول ارم ما كانوا بيعملوا لهم لارنجوسكوبي.
بالله
intervention patient ايوه. فأنا قلت يعني we'll spend a few minutes just talking about what we already know about surfactant use and CPAP and MIST or LISA, and then we'll move on to the trial, so we won't spend a lot of time here. فإحنا يعني a long time ago قبل ال wide use of CPAP أنتوا شايفين الارrow حقي صح؟
yes
أنا شايفه.
تمام. فيلا فدي الكوكرون ريفيو بتاعت البروفيلاكتيك versus selective surfactant administration. وبefore the widespread use of CPAP, دي كل الستاديز دي كانت في ال 90s, early to mid 90s. There was a preference or there was a improvement in mortality and BPD in the patients that were given prophylactic surfactant. And then the studies that came later in the 2000s where CPAP was used for the control arm or the selective arm, that benefit to mortality and to mortality disappeared. فواضح إنه هو CPAP يعني at least precludes these babies from needing to be intubated and given surfactant, and we can be a bit more selective. So after this meta-analysis came out, most centers moved away from prophylactic surfactant administration to selective surfactant administration and early use of CPAP. This is another meta-analysis that analyzed the same data in addition to a couple other trials, and they looked specifically at whether comparing CPAP with intubation and surfactant administration. فحتلقوا إنه في مثلا support trial and done trial that were included in the previous meta-analysis, and then a couple more. And it also shows that using CPAP compared to intubation and surfactant administration is superior when it comes to death or the composite outcome of death or BPD. After these studies, that also supported the move away from prophylactic surfactant administration and starting CPAP early. But then the question came up, okay, so maybe if we know that when we intubated both groups and gave surfactant, there was an improvement. Ma'anata surfactant is good for babies, but then when we took away the ventilation, that the intubation ventilation, that benefit went away. So the question was, is it the fact that you intubate and ventilate patients is what's harming those patients? That's where the idea of minimally invasive surfactant therapy came from. And this is a trial that compared meta-analysis that compared surfactant administration through MIST with Ensure to see if there is a benefit to MIST, and it does show that. So it does show that when we're looking at death or BPD, the composite outcome, surfactant administration through MIST is superior to surfactant administration through the Ensure procedure. And that's both in patients that got Ensure and patients that got ETT, surfactant, and delayed extubation. The big limitation, I think, with this paper is that it included only a few babies that were less than 28 weeks. So it might not be generalizable to that lower gestational age. So then this research question came up. So for the OPTIMIST trial, the question was, for preterm infants that are 25 weeks to 28 plus 6, supported on CPAP for RDS with FI to requirements more than 30%. Does the intervention of MIST within 6 hours of birth and continuing CPAP versus sham procedure and continuing CPAP improve the death or the composite outcome of death and BPD, death or BPD, sorry, that was a mistake, death or BPD by 36 weeks of corrected gestational age? In terms of the methods of the trial, the inclusion criteria was 25 plus 0 to 28 plus 6. babies that are on CPAP 5 to 8, FiO2 requirements above 30%. Age has to be less than 6 hours, and they were all inborn. Exclusion was for babies where the respiratory distress was not because of RDS. They had a prior intubation, مثلا the babies that were intubated in the delivery room. If they were thought to imminently need intubation, so that included babies that have oxygen requirements more than 45%, they were excluded from the study, and then serious congenital anomalies. They got prenatal or postnatal consent, which is important. There wasn't selection bias for babies that came from more stable pregnancies or delivery situations, I guess. The treatment team was made of a MIST-trained proceduralist, وإحنا استسمعنا إنه محمد كان one of them. بعدين, in addition to that, there is a nurse, and these people have to not be part of the patient's clinical team. Randomization was web-based by the treatment team, and then they were stratified by gestational age and center. I think this speaks a little bit to what Wafat was talking about earlier. So the method of MIST that they used in this trial was the Hobart Method. They used no sedatives, but the babies were allowed to get sucrose or non-pharmacological measures for pain control. They did get atropine if the team felt that they needed atropine, but it wasn't protocolized. And they got Curasurf, and it was 200 milligrams, so a standard dose. It was instilled in 3 to 4 minute aliquots. And I inserted the video here, لكن ما عارفة لو في interest in the group to watch the video. It's a 3-minute video. ولا I could just send the link. I mean, it's easy to get يعني.
دي لحظة يا دلال. بتحبي ناس يعني يقاطعوك ويسألوك الأسئلة، ولا تحبي الأسئلة كلها في الآخر؟
لا قاطعوني واسألوني، ما في مشكلة يعني. أنا I think it's nice, should be interactive يعني.
خلاص كويس. هاي شغل فيديو. I'm very
If you send it to the group, it will be better يا دلال. Send the video in the group.
خلاص I'll send the link as well. طب الناس عايزة تشوفوا هنا أو send the link ولا؟
أيوة نشوف في الجروب لما كنا
شغالين، ورسل لنا اللينك برضه.
خلاص تمام. Okay, is the video playing for everyone?
شغالة بالنسبة لي.
طيب كويس. أنا ما عارفة لو الصوت هيجي ولا لا، لكن it probably is not important anyways يعني. طيب في زول بيعرف يشغل الصوت كيف؟ في تخيلي مش مع زوم صح؟
دي اللي تعمليها في السيتنج من عندك، انك تشير الفيديو بتاعك، تشير اسمه ده، تمشي الزوم بتاعك في الحته بتاعت شفت الحته اللي فيها الميكروفون دي؟
اوكي.
تمشي تختاري حاجه انه تشير يور او شير سكرين، تشير الاوديو من الكمبيوتر ذاته، او انت كان اديتيني كنترول. I think I can do it.
طب how do I do that؟
كده اعمل شير اجين، اعمل شير السكرين بتاعتك كده. شوف انا اذا قدرت اعمل اسمه ده، شوف اذا قدرت اسك فور كنترول. عندي حاجه زي دي request remote control.
لا ما ايوه هاي هندي جاتني. اوكي approve. go ahead.
Okay, let me see. Okay, هي لحظة. تخيل ما بقدر اعمل لها يعني، ما بقدر اخش من عندك، لكن الاوبشن بتاع الشير المفروض اللي بتعمليه انت المفروض يكون اوبشن نت. شفت الحته الجزء بتاع ادفانس في الشير لما تعمل شير؟
اوكي لكن لازم اعمل ستوب شير اول واعملها ثاني صح؟
اي
شير
الاوبشنز فوق بيجيك حاجه زي اسمه ده ادفانس.
ايوه
فيها بقول لك شير كمبيوتر اسمه ده اوديو الحاجه زي دي.
اوديو ايوه
بس كده اعمل عليها، والثاني ثاني شوفي اذا الصوت وصلنا ولا لا.
Okay, and then طيب أنا هسي عشان أرجع أعمل share تاني أعمل share screen 1 second
ايوه
go back to basic.
احنا حاسس ظهرت لنا حاجه اسمها دلاله الشيرنج اوديو سكرين.
خلاص أوكي يلا نرجع لها ونحاول تاني.
كان ما اشتغلت ما مشكله في اللينك
طيب خلاص دي آخر trial لو ما اشتغلت we'll move on يعني I can speak through it يعني.
فيها مزك من الاول طوالي ولا
لا بتبدأ بعد
فيها
شوية.
زول بيتكلم؟
يظهر بيتكلم بعد شوية هو هسه لسه المفروض يبدأ هنا. أوكي خلاص لو ما بدت ما مشكلة فهم
ما مشكله.
they position the baby in the sniffing position. They put a shoulder roll. The babies are maintained on CPAP during the procedure. بالنسبة للcomfort بيستعملوا السوادلينج sucrose لكن ما في medications. بالنسبة الانترفيس دي وحدة تخيليه من ال considerations عشان لو مثلا واحد عنده an infant flow interface حيكون in the way when you're trying to do a laryngoscopy. فلازم يكون interface بيستحمل إنه الواحد يقدر يعمل intubation. so حاجة زي الهسي في الفيديو أو الرام كانيولا أو كده. بعد كده بيعملوا laryngoscopy. وهم في الهوبارت method they use a stiff cannula ما بيستعملوا feeding tube. هي كانيولا معينة للبروسيجر ده. الكانيولا is pre-marked for the insertion depth. Well, insertion depth is 1.5 centimeters below the cords in babies 27 weeks and less, and 2 centimeters in babies that are older than 27 weeks. Okay, but then they adjust it to the correct insertion depth. بيطلعوا laryngoscope, they hold it in place, and then they administer the surfactant. بعدين حتلاحظوا إن هم they don't move the baby, يعني the baby is lying supine throughout the procedure. They give the surfactant in 3 boluses or 4. The baby is spontaneously breathing during this time, and the idea is that spontaneous breathing allows for better dispersion of surfactant.
ده بلس صح؟ عشان كده الفوليوم كبير شويه.
تخيلي cure surf.
بالله.
well I mean في الستدي كانت cure surf. في الفيديو ده هل ممكن كانت تكون بلس؟ I don't know. ما تكلم عن weight of the baby. لكن ما شكلها كان أكثر من 2.5 mils يعني. أوكي. طيب في أي أسئلة عن الميثود ذاتها بتاعت installation؟
This is much better than the feeding tube.
Then شنو sorry?
Than the feeding tube, much better because we were using Lisa with a special feeding tube. This is much better. This rigid catheter.
أيوة أنا I agree وفا نحس يعني for a very brief time لما كنت في الريزنسي استعملنا الفيدنج تيوب لأنها very flexible بتحتاج المجال صح؟
أيوة exactly.
فدي مفروض تكون يعني a little bit more straightforward مفروض ما تاخد as much time يعني.
Very nice.
هي لكن أليزا has its own catheter صح؟ يعني ما قاعد نستعمل الفيدنج تيوب.
لا في تيوب كده عملوها like a feeding tube معاها زي حاجة زي بلاستيك كده بتكون زي guide. You should just يعني لكن it's not that good. مع إنهم ركزوا كتير لكن this is much better. This vascular catheter أحسن. لا تدوها التيوب فبتديك كأنك بتدي انشور يعني.
والكاثيتر ده 16 جيج لكن يعني أطول من الكانيولا بتاعت الاي بي اي. يلا بعدين بالنسبة للcontrol group they were maintained on CPAP. They did move the patient to the يعني to reposition the patient as if they were going to intubate. بعدين محمد بيكون بتذكر إنه they pull curtains around the patient عشان يتأكد إنه ما في زول من برا بيقدر يشوف what's happening يعني for blinding. Team interactions they keep it similar to if they're actually delivering the surfactant. They talk through the procedure, they take the same amount of time similar to the intervention group so that the يعني clinical team برا administration ذاتها ما يكون عارف allocation بتاع البيشنت شنو. بالنسبة لل2 groups, they discontinue them from the main monitors in most sites, and they put them on a study oximeter for saturation and heart rate monitoring. بالنسبة لأي patient in either group, if their FiO2 requirements rise to above 45%, they get intubated to receive surfactant. If it's above 40%, it's up to the treating physician's discretion. So some patients are intubated at that threshold. وإذا عندهم significant apneas, persistent respiratory acidosis, any other indication for intubation, then they get intubated. MIST is not allowed after the intervention in both groups. So they're randomized in the beginning, they get MIST or they get control, and that's it. They don't get MIST again. The outcomes that they looked at were the primary outcome was the composite of death or physiological BPD at 36 weeks. BPD was assessed by a blinded study personnel. So the person who assessing for BPD was not involved in the administration. Their diagnosis for BPD was mechanical ventilation or CPAP or high flow more than 2 liters per minute at 36 weeks, or the need of supplemental oxygen with actual or effective FiO2 above 30%. Or oxygen with FiO2 less than 30%, but the patient either failed a room air trial or the room air trial was not done based on a physician request. Other outcomes that they considered, they looked at clinical and safety outcomes, the ones that are listed here. And then they also looked at other complications of prematurity and all the respiratory support outcomes. And they monitored how long the patients needed mechanical ventilation, CPAP, oxygen, and so on. For analysis, and I just wanted to say, أنا بالنسبة لي statistics is a foreign language. فإذا أي زول فاهم analysis more than I, يعني please help out يعني. لكن anyways, they calculated risk, relative risk, mean and risk difference. Or they also used the generalized linear modeling to correct, I guess, for confounders. Sample size that they calculated in the beginning was 606 to detect a third reduction in the composite outcome with a power of 90%. But it's important to consider, their recruitment stopped at 81%. So they had a little bit over 400 patients because of the start of the pandemic. All right. So, as you can see, more than 5,000 patients were screened. About 4,000 of them were excluded because they didn't meet eligibility criteria. 1,000 were eligible, and they randomized 488. Of course, the patients that were not included are important to consider عشان نتأكد إن هم they don't affect the results of the outcomes, or no important groups were excluded. There's 15 that were excluded based on the decision of the treating physician, so it's not a big number. So I think the chances, probably the risk of excluding sicker patients or patients that the physician feels that they actually do need surfactant maybe was not significant, but I just want to also state that there was 292 patients excluded, or not, I shouldn't say excluded, but not enrolled with no stated reason. So some of them might be, that might affect the results to some extent
برضه الأسباب الخطيرة دي فيها أول مرة ألقاها في ريسيرش، مثلا not permanent resident ده عشان الفولو اب تعرف بيه، ولا في سبب ثاني؟ الحاجة الثانية بتاعت language barrier دي it's very strange.
تخيلي بس عشان الكونسنت يكون informed، يمكن ما قدروا for effective effective communication مع الفاميلي. لو في language barrier then the consent is not informed، صح؟
بقى على حسب، مثلا بقول في ادمنتون ما لقوا زول يتكلم فرنسي مثلا، هل يعتبروها language barrier؟ او ما لقوا زول يتكلم اسباني، هل يعتبروها language barrier؟ it's just very very strange.
لكن النمبر is small, so أنا I'm gonna assume إنه هم they tried، ولو لقوا زول إنه لقوا زول يجي to translate then it's a go ahead. لكن إذا ما لقوا زول to translate they don't. أنا عارفة إنه مثلا at least I can speak for Edmonton، لما يكون ال research team محتاج يتكلم مع family that speak Arabic they usually come and find one of us، صح؟
Yes, yeah.
بالنسبة للrecruitment في Edmonton they do look for someone to translate. ولكن it's a good point محمد، لأنه إحنا we want to make sure إن هم they're not excluding مثلا a subset of the population، صح؟ the good thing about this trial إنه هي it's multi-centered. يعني if in every center they excluded people with language barrier, طب it makes the results maybe not as generalizable صح؟
ايوه طبعا، بالذات انه مع الريسنت بانديميك دي وورد كيف انه الريسيرش مرات ما بكون انكلوسيف لكل الناس، not representative لكل البوبوليشن.
صح. عشان كده انا يعني شنو it's worse يعني انا I'm not a trialist، لكن يعني انه the fact انه they had almost 300 patients not enrolled وما في سبب it's يعني it's a bit concerning، لأن الواحد ما عارف okay ال patients دول كان شكلهم شنو، there's no information about their characteristics أو كده يعني. لكن يعني if we take it on, by face value يعني we assume إنه ال 488 patients there were actually representative of the population, and then we move on. And I think it's hard for us to find out, you know, يعني why that happened.
Yes.
طيب about half of those patients were randomized طبعا للمست و half of them were randomized to receive the control. بالنسبة يعني اسمه شنو the retention of patients in the study was very good. I mean part of it probably عشان patients كانوا study was completed while the patients in the NICU. So out of the 244 that were randomized to receive control, there were 240 that was included in the as-treated population analysis, و 244 were included in the initial analysis اللي هو كان معمول ب intention to treat analysis. طيب هنا if you look on the side you're going to find that no, there were a few patients on each arm where there were mistakes that happened and then they crossed over to the other group. It was a small number. لكن it probably was addressed لأن هم they did intention to treat analysis at the for the primary outcome, and then they did as treated analysis, and they did per protocol analysis وكلهم كانوا they had the same results. So I think we're probably fine in terms of this few patients that crossed over. يلا دي characteristics بتاعت patients. فالمذكرين طبعا ان patients كانوا 25 weeks to 28 weeks. المين age بتاع patients كان 27 weeks. That probably just reflects the fact that we usually have more 27 and 28 weekers than we do the younger gestational ages. The babies were about 1,000 grams in weight, a little bit shy of that. And the characteristics were similar in the two groups in terms of you know, how many were small for gestational ages and so on. So I'll give you a second to look at it. لكن the one thing to note, which is not reflected on this table, is that for this younger gestational group, so 25 to 26 weeks, there were significant differences between the baseline characteristics between the two groups. So the missed group in the 25 to 26 weeks had more males, had more no steroid exposure, and had more multiples in the intervention group. So that طبعا can affect the results for sure. لما أخذت الجروب كله مع بعض, the differences were not significant. لكن for the younger babies, it was significant. البرايمري outcome بتاعهم طبعا كان composite outcome اللي هو death or BPD. هنا the p-value was 0.1, so there was no significant difference. And the risk difference was negative, so it was leaning towards the trending towards missed. لكن طبعا احنا عارفين we shouldn't just go by trends. لكن it was trending towards missed, لكن it did cross 1, so it's not a significant result. Death was also the same between the groups, but it was on the positive end, so it's suggesting that and the missed group had a little bit of a higher death rate, but that difference was not statistically significant. The only thing that was statistically significant was BPD. So BPD was seen less frequently in the missed group compared to the control group. It was a risk difference of -7.8 and a relative risk of of 0.83. And the numbers did not cross 1, as you can see. So this was a significant result with a p-value of 0.03. When they looked at the safety outcomes or key clinical outcomes, pneumothorax requiring drainage was significantly reduced in the missed group. Need for intubation was also significantly reduced in the missed group, with a pretty impressive relative risk. Yani it was reduced by about a half. Yani that is pretty impressive. P-value, as you can see, was very significant. The other safety outcomes or clinical outcomes were not different on this page.
This is pneumothorax requiring drainage. يعني ممكن كان في minimal مثلا pneumothorax خلوها to resolve on its own يعني in the group صح؟ يعني مش كلهم the big ones.
بالضبط كده بس هم they only reported significant pneumothorax لكن بالنسبة لل small pneumothoraces that didn't require treatment they didn't report them in the paper at all. Okay.
في دلال فكر احنا it's safe to assume انه كل السنترز اللي participated في الستادي دي use volume guarantee صح؟ بالذات مع النيموثوركس دي.
والله يا محمد I'm not sure. I'm not sure. It's a good question. أنا ما عاينتها لكن هم there are 33 centers يعني ففي احتمال إنهم يكون جزء منهم they're not using volume guarantee. You're right.
Okay.
لكن هم when they did their analysis الفانسي statistical analysis ما قاعد أفهمه كويس ما كان في differences هنا per site يعني ما لقوا trends that show in one site had مثلا one complication more often ولا كده. So hopefully that answers your question. لكن أنت عارف بالنسبة لنا إحنا في إدمنتون we use هنا use volume guarantee. المين sites كانوا في أستراليا وبعدين they also use volume guarantee to, as far as I know من بس their presentations يعني لكن كان في other centers that I'm not sure about. بعدين this in terms of the secondary outcomes it's a busy slide لكن أنا I just put arrows where the difference was significant. So intubation at any time was significantly reduced. Requirement for surfactant therapy via ETT tube was significantly reduced. Home oxygen was significantly reduced. And interestingly, PDA requiring medical therapy was also significantly reduced. وتحت حتلقون الأوتكمز بتاعت الفنتيليشن كلها were significantly reduced. So these patients needed less mechanical ventilation, less days on CPAP, less O2, and so on. The rest of the outcomes were similar between the groups. دي بس كنت عايزة أوري يعني subgroup analysis just given that احنا عارفين إنه يعني there a lot of times there is a difference between the 25 to 26 weekers and the older population. So they did divide them by gestational age strata. It was interesting to see إنه a death prior to 36 weeks there was a treatment effect difference ما بين the younger patients with older patients. So it favored the control in the younger patients. So the younger patients died less in the control group. Or it favored the intervention group in the older gestation. لكن يعني what was significant was the difference between the gestational ages. لكن within each gestational age, when they compared them, that was not a significant value. لكن the study was not powered to look at the effect of this intervention on the separate groups. It was powered for the whole group together. It could potentially be worrisome for the younger babies. Like at the same time, we go back and look at the fact that the smaller babies were not the same. Were not similar in the two groups. So that can also affect the results. They were dying more often in the missed group. Like these babies were more male, didn't have steroids, and had more multiples. So the higher death rate might be due to that, but not due to the fact that they were in the missed group. So, like it's just a caution, صح? بالنسبة للother primary outcomes, death or BPD ولا BPD alone, ما كان في difference treatment effect difference between the gestational age strata. Okay, this concludes my presentation of the study, and I thought we can go over the validity of the data وكده وبعدين we can have a discussion. لكن برضو زي ما قلت please interrupt at any time لو في questions ولا comments. So these are my answers. Tell me if you agree ولا لا. Is the data valid? This was easy to go through. لأنه this study was really, really well done. فيعني ما كانت hard to go through it أو ما كان في critiques كتيرة للstudy دي. Was it randomized? Yes, it was randomized. Was the randomization concealed? Yes. And I can tell you from personal experience, at least in one center, it was really hard to guess what the patient got based on what the team was doing. Was it intention to treat analysis? Yes. هم عملوا intention to treat analysis as their primary outcome, and that's what they presented. لكن when you look at the supplementary, they also presented their per protocol and as treated analysis. وما كان في difference between the results. Were the gestational group, were the groups different, intervention and control? overall, when you look at the whole group, they were similar. Like when you look at the 26 to 25 and 26 weekers, there was differences between the two groups. So the MIST group had more males, had more no steroids, and had more multiples. So potentially they were at risk of poorer outcomes to begin with, حتى قبل ما they received the intervention. So I'll pause here. ووروني يعني, do you guys agree with this, with how I interpreted the data here, the validity of the data?
Yes, I do.
اتفضل يا وفاء.
I do agree with the validity of this result.
افتكر the result is valid. يعني بذكر حتى ان احنا لما عملنا الادمنستر البتاع ده، هو جبنا الكيرتين بتاعه، ما في زول كان عارف يتواحد، وحتى يعني الداتا بتدخلها في الكمبيوتر وده، فكانوا very few يعني people that are involved في التريتمنت they know. I don't think there is any question to يعني the outcome of the result. يعني الحاجة الوحيدة بس إنه السامبل سايز كان ممكن يكون أكبر بس لو ما البانديميك.
مظبوط. يعني I agree محمد إنه honestly I think the blinding in this study was pretty impressive. يعني to actually be able to blind surfactant administration is very difficult. صح؟ يعني حتى I think if I remember correctly support was not blinded. يعني في some of the trials اللي هم احنا هسي يعني we use them خلاص ده landmarks حقتنا، الrandomization فيهم ما كانت concealed يعني، لكن هنا it was impressive يعني. طيب, did the intervention and the control groups retain similar prognosis throughout the study? Yes, لأنه patients والfamilies والclinicians كلهم كانوا والassessors كانوا blinded to the randomization. Was the follow-up complete? Yes, لأنه كان في بس one consent withdrawal. So the vast majority of patients were followed towards the until the end. لكن the big issue is what Mohammed just brought up, إنه the enrollment was not complete due to COVID. So I think طبعا enrollment stopped لما وقفوا trials في most centers في March of 2020. في الأول they left it open for some time يعني thinking maybe they can go back to study soon. لكن عشان الموضوع جرى they decided to end the study early and publish.
At least they covered 81% of what they were planning to, صح?
صح.
But I think it's powered enough to detect the outcome despite that earlier.
It's true. لكن يعني I guess الquestion إنه هم في الأول they started with a high power. يعني they started with 90% power in their calculations. They didn't start with 80%. ويمكن ده السبب يعني maybe وفاء that يعني that's what they were considering too. إن هم لا they started with a higher power معناته we might have enough patients. لكن we ended up with a non-significant difference when it comes to death or BPD. صح, primary outcome. فهل مثلا لو كانوا تموا study and they actually recruited 600 patients,
they might get a difference يعني.
يمكن الريزلت كان فارق.
Maybe.
فيعني الكونكلوجن هنا كانت إنه أو الريزلت إن هم they did not reduce the composite outcome of death or BPD, but they did reduce the absolute risk, the absolute risk of BPD by 8% in survivors. They reduced pneumothorax and need of intubation by about half. They reduced the duration of all respiratory support. So this is my take on it. لكن كنت عايزة برضو أوريكم الكونكلوجن بتاعت الauthors لأنه it's a little bit different. I shouldn't say different. لكن هم لأنه they have to focus on their primary outcome. صح? So I'll give you a second to read it. So if you're like me and sometimes you just look at the abstract of an article and you jump to the conclusion to see what it says, you might think, okay, خلاص معناتها MIST didn't really make a difference. انسى الموضوع, move on to something else. Which I'm not sure if that is true in this case. لكن هم they do put that caveat in إنه هو it's uncertain إذا كان في important effect that cannot be excluded. صح? So yeah, so I wanted to start the discussion and I thought maybe we could start with the fact that يعني there was lack of improvement in the composite outcome. لكن there was a reduction in BPD. طيب هنا what's more important بالنسبة لنا؟
طبعا أنا I always hate the outcome بتاع death or BPD لأنه الاثنين different بإنك you live with chronic lung disease وإنك you die يعني. I always hate لما يخطوا حاجة مع بعض.
أيوة.
لكن الحاجه الثانيه اذا ممكن ارجع انه هل ود عشان الكومباريزون بتاعتهم ما كانت كلير بالنسبه لي، لانه الاستدي اللي عملوها انه they wanted to compare هل انه giving surfactant through minimum invasive procedure to not giving surfactant والاثنين to stay on CPAP ولا also at what level of oxygenation انت you give surfactant ولا that will make the difference. هل كان المفروض انها proper انها to be compared انه ليزا or mist against insure against sham عشان تشوف الأحسن يا تو؟
There was actually like that in 2016.
عملوها؟
أيوة اتعملت 2016. اتعملت زي network analysis. It compared the LISA, it compared the insure versus CPAP. وكل non-invasive methods through NIPPV compared برضو سواء كان synchronized or non-synchronized. It compared a lot of non-invasive methods of ventilation to LISA وإنشور وكده. فهم كانت أنا إن شاء الله حلقة وحبعتها لكم في الجروب. كانت it was يعني it was favoring LISA in يعني حاجة كده unbelievable, too good to be true حتى. فكان في study زي دي. إن شاء الله القاها وارسلها لكم في الجروب إن شاء الله.
وكان عملوا فيها بريك داون للناس اللي يشوفها على الأقل من مثلا اللي هو الفيري اكستريم بريماتيور ناس 25 6 يعني 25 و24.
أنا قدمتها لما كنت F1 في 2017. فكانت جديدة شوية لكن I need to look at it لأنه كان فيها very complicated statistics و network analysis لأنه it allows you to compare حتى حاجات ما compare مع بعض يعني. ففيها I will look to it وأرسلها لكم إن شاء الله. فيها very complicated.
لأنه إحنا what we know before the study the optimist إنه prophylactic surfactant براها يعني it's not necessary and you may end up doing harm rather than good. Therapeutic surfactant we know it's good and we know إنه CPAP is better than invasive ventilation. فما أعرف تفتكروا الأوبتيمست دي what did it add للحاجات اللي already بنعرفها دي؟ إنه بس يعني to confirm إنها done more probably with blinding الحياة دي كلها just to confirm what we already know ولا تفتكر شنو هذا؟
لا أنا تخيلت a little bit different يا محمد لأنه يعني حاسة أنا ما عارفة لو الستدي كانت بتتكلم عليها وفاء was included in this meta-analysis ولا لكن الميتا-analysis دي هسي it shows إنه surfactant versus mist versus surfactant versus ETT. Surfactant versus mist is better than surfactant versus ETT. فإحنا دي I think this data is pretty robust. This doesn't need to be done again in the gestational age groups that were included. المشكلة مع كل studies there إنهم they included a very small number of babies under 28 weeks.
Oh, okay.
وما في 23 weekers كله في very few 24 weekers. يلا a different what does this study add? And the studies that were done in the past that compared prophylactic versus therapeutic, that compared surfactant through mist with surfactant through ETT, they all had a higher threshold to treat. So they all had, most of them had a threshold between 40% to 60% to treat with surfactant. لكن هم what they were trying to investigate, if we intervene earlier, we intervene at 30%, not 40%. كويس? And we intervene with minimally invasive that we know is better than intervening with ETT compared to doing nothing, just giving the baby CPAP. Because we know that CPAP is good, صح?
Yeah.
Do these patients do better ولا لا? So we're not talking about the patient اللي هو أنت من زمان متأكد إنه هو خلاص محتاج surfactant. We're talking about the babies that needed a little bit less O2. So between 30% to 40 or 30% to 45% O2.
Okay.
Which actually begs the question يعني إنه طيب الثreshold بتاع treatment بتاع surfactant شنو في الجروب يعني أنتم بتستعملوا what FiO2 on non-invasive support to give surfactant?
We use 30%.
30.
40. I personally use 40.
40 for those above 28 weeks, right? حسب European consensus guidelines اللي هي بتاع 2000.
I was going to say we use 30 as well, based on the European guidelines.
إحنا على حسب once احنا بندي الاشعه فرقه كده يعني if he persistent more than 40 for 1 hour هتبقى كده بنديه surfactant. اذا كان هو ناس 35 وكده وممكن تتغير نديه فرقه انه maybe will go to 30 or below. لكن if he sustained above 30 وصل ل 40 and continue for at least 1 or 2 hours بعد كده بيدوه surfactant.
طيب ممكن أسأل بالنسبة للناس اللي بيستعملوا 30% ما 40% الإيفيدنس هل في evidence ل using it at 30؟ أنا تخيلي there's a lot of expert opinion. أنا برضو هسه I use 30 لكن I struggle to find evidence for using it at 30 and not 40.
No, we're actually following the Eurocensus guidelines بس. أيوة. فأنا
I think the Eurocensus guidelines is also based on research. I remember there was NASA CuraSurf. They once did a presentation in our department, and usually I'm very skeptical when the pharmaceutical company comes and does research, but they presented evidence about the difference between targeting 40% and 30%. I think there is evidence out there. I'm not sure. I haven't read it personally.
What age group? What age group you're talking about? The 30%.
So
generalized
28 weekers and below.
أيوة يعني زي اليوروسنسس نفسها.
Okay, that's excellent. طيب نرجع لل point of discussion. Does the fact that the composite outcome was not changed negate the reduction in BPD, or would you take that as a positive and say MIST reduces BPD? That's an important outcome, despite the fact that BPD and death is not lower. برضو يعني you have to take into consideration إنه death was not higher in the group. ولو في زول بيفهم في statistics أكتر مني if they can explain that to me that'd be great.
السياسة دي معظمة صعب واحد يخش لا كده كل ما تفهمها وما تستعملها بتنساها فمحتاج انك ترجع تفهمه. لكن عموما انا افتكر انه في reduction في البي بي دي is very important يعني especially في it make a lot of quality of life difference اللي يشوفها بعدين.
I think
the only
sorry, go ahead.
I think the only difficulty is that could you actually I know it's there was a reduction in BPD, but once you've powered a study and you've said that it's not statistically significant or not, then you can't gauge whether there's confounding or not, whether it's purely because of your research or is there something else affecting it. That's the only restriction.
And I think, I mean, the result of reduction in BPD was statistically significant, so I don't think we can ignore it. Like the only problem with is that if BPD is lower, but your composite outcome is the same, it begs the question, was death higher? صح؟ لأن dead babies don't have BPD. They die before they're diagnosed with BPD. لكن هنا in this case, death was, was not statistically different. So, I mean, I think it's just...
Yeah, sorry, I meant the death bit. Yeah, not the BPD, sorry.
أيوة طب yeah, there you go. فعشان كده يعني it's هنا I think the difference is probably real in this case. إنه فعلا كان في reduction in BPD without a significant increase in death. So the next point that I wanted to bring up is a hypothetical patient. So a 27-weeker, 3 hours old, on CPAP of 35%, no apneas, no respiratory acidosis. The first question was going to be, what do you currently do? And I think we got a little bit from the group. Like, and if anyone else wants to speak up and tell us what they would do with a patient like this currently.
I just if I may say one thing, a significant study like this, at least from my point of view, in معظم السنترز at least اشتغلت هنا في UK, they are very reluctant to use CPAP or give surfactant only for treatment, not prophylactically. فعشان كده studies زي دي is very handy لأن it will force you not to sedate البيبي ده تديهم morphine routinely وإنك اسمه ده to take the tube حتى لأنه في insure some تديهم pre-medication تديهم insure بعد كده تلقاهم flaccid after ال pre-medication وما راح نخلي ال ventilation overnight ما دارين مشاكل أو تلقى الصباح وبعد كده الموضوع بيجر. فstudies دي إنه will force you to use CPAP more and will force you to use not to use sedation. وانا already شايفه زي ده بالنسبه لنا. I'll give him a little bit more time. As I said, I usually will take 40% as a cutoff point. ما أعرف باقي كيف.
حتى 27 weeks يا محمد.
حتى في 27 weeks. اليوم ده كان عندنا هم 27 weeks plus كم يوم كده الاثنين. عملنا لهم بس هو سي باب. واحد فيهم احتاج افتكر surfactant after 6 hours. وتومو محتاج. والcut off point كان 40.
Okay. يعني some of them will really tolerate the 40%.
اي جا brain sepsis later on, but that's not related.
احنا والله الغريبة for us انه it's rarely for 27 weekers not to be intubated in labor ward للأسف يعني. rarely عندنا تلقى 27 weeker not intubated in labor ward حتى. يعني he's brought up to the unit intubated. ده عندنا usually this is our statistics يعني في المستشفى العسكري في الرياض. لكن to the experience of those who attend the labor ward يعني مثلا they don't give the baby a chance to breathe spontaneously حتى لو في شوية struggle at the beginning. ولا الارتيز نفسهم المعانا كمان ما كان عندهم experience شوية إنهم to apply proper CPAP so the babies will end up intubated. يعني إحنا إلى الآن الجايدلاينز بتاعتنا ما تغيرت من البروفيلاكتيك surfactant due to these technical difficulties. experience of the RTs. وكمان عندنا مشكلة ثانية إنه الليبر ward is 2 stories below the NICU. فهو to get the babies from here to there on CPAP through the elevator برضو it creates a problem. والproper application of CPAP. فهي دي كلها عاملة عندنا إنه البروفيلاكتيك surfactant is still used in my hospital. ما لسه
What interface do you use on transport from labor ward for the CPAP? Is it nasal CPAP or is it just via a T-piece or?
لا nasal CPAP عندنا
nasal CPAP.
طيب they try to apply nasal CPAP.
والله افتكر انها just يعني شنو هي unit will لانه احنا عندنا حسي في اليونت اللي شغال فيها انا احنا we move them من الليبر وورد او الثياتر لليونت ما بعيده. we only use mask and neopuff عن طريق السي-باب عن طريق النيوباف. and they make it fine يعني.
It's the culture, it's the unit's culture basically and understanding. We use T-pieces as well. يعني it's not as secure as the nasal CPAP, but we transfer them absolutely fine into the unit.
Okay.
Northeast of England, RVI, Royal Victorian Infirmary.
your hospital is big يعني اليونت حقتكم عندها
it's a tertiary neonatal unit that deals with surgical, cardiac and ECMO, so it's quite a big unit.
well equipped عشان كده بيكون عندكم outcomes are good.
But I think it's also cultural, just the understanding that babies at that gestation can possibly survive on CPAP. They don't necessarily need to be intubated and given surfactant. Like in my experience with the 27 weekers and below is usually that they kind of like, you know, jog along for 24-48 hours, but unfortunately most of them, some of them can sustain on CPAP, but most of them after a while they do tire out.
طيب وفاء كنت بس عايزة أقول ما في عندكم في اليونت ما في labor and delivery ما في stabilization area يعني بتكونوا في الريسسيشن بتكونوا جوا الغرفة
مع المذر
تكون قاعد
في راسك وهم they trying to know the outcome of the baby وعايزين يعرفوا intubated ولا they create a lot of fuss هناك يعني حتى لو في كمان a baby who needs intensive or extensive resuscitation they create a big problem for you يعني بتلقى التيم طوالي بقى disorganized وما coordinated وكده
طبعا
أيوة فهم
يعني أنا I guess the question is لأنه أنا اشتغلت في 2 units يعني كان نفس السيتويشن إنه labor and delivery في floor والNICU في floor مختلف أو بعيدين من بعض لكن يعني الحل كان إنه يكون في أوضة في labor and delivery where the baby can stay for an hour or 2 or 3 عشان كل stabilization تحصل هناك.
أيوة والله could be better.
بس تكون في أوضة مختلفة لأنه بجد يعني إنه شغالين في resuscitation في الأوضة بتاعت الولاد دي حتكون صعبة شوية so I understand.
أيوة
طيب the next question has a lot of people in the group already intubate and give surfactant at 30 or whether by mist or intubation they give surfactant at 30%. فعشان كده هسأل محمد, does this study change your practice from 40% threshold to 30% threshold?
I don't think so. I mean, at least anecdotal the experience في some of those kids who بالذات الكبار 27 وأكبر منهم sometimes 26 they manage بالذات إذا كانوا females they manage and the steroids on board they manage actually to once they reach 35 they manage to come down the next day, especially if you are able to tolerate that you give them a PEEP of 8 up to PEEP of 8 عشان to improve the oxygenation. If you're going to let them stay in the PEEP of 5 or 6 احتمال you will fail.
طيب that's a good point. لأنه in this study they did encourage everyone to dial up the PEEP to 8 if the babies are requiring oxygen. So they did what you're saying. Well, they showed a reduction in BPD, reduction in pneumothorax. كان في outcomes كتيرة that improved. Why wouldn't you change your practice? ولا is it because mist is not feasible?
لا حتى في اليونت بتاعتنا still hasn't been up. يعني الميثود of giving the method of giving steroid is still ensure اللي هو intubate وتديهم steroids surfactant to extubate لسه still ensure. لما تيجي ليزا يعني for the sake of getting rid of intubation or pre-medication هذا دي افتكر regardless 30 40 افتكر it will be a good practice anyway, even if the protocol say that we have to be less increase the threshold, reduce the threshold to give surfactant. I don't think it's a big sacrifice ولا حاجة. Especially in the trauma هتكون less with the intubation.
Okay, perfect. Thank you. أنا بالنسبة لي لأنه أنا من اليونت البروتوكول بتاعنا ولا هو it's not even a protocol لكن a recommendation إنه to give surfactant about 40%. لكن a lot of us that trained in different centers used 30%. For me, this study would reinforce what we're doing, especially what I'm doing, especially إنه إحنا هسي most of the patients that were included in this group would be given surfactant through mist. And not through intubation and ventilation. يمكن when you get rid of the intubation part, ممكن واحد يكون more comfortable given surfactant. And it's true. we can't generalize the results of this study to giving surfactant through a tube. They didn't compare giving surfactant through a tube to CPAP. They compared mist through to CPAP. But that's very reasonable. Any other comments on this point? I have a few other discussion points.
Not related specifically to this point, but what kind of training did you receive for delivering surfactant by non-invasive route, and how long did it take to kind of cover all, especially new trainees that are rotating and things like that?
طب بالنسبة لنا نحن للexperienced intubators it was see one do one. فبيجيبوك الناس هم أصلا the mist practitioners بيوروك how to do it. You get trained on a doll first. Using video laryngoscopy, and then you do it on a patient after you are deemed confident doing it on a doll. Then you do it on a patient afterwards. بالنسبة للnew trainees, they have to achieve competency for intubation first before they get trained to do mist. Once they're competent for intubations, then they get trained to do mist the same way. Does it take long? لا لأنه honestly الفكرة ما مختلفة شديد بالstiff catheter than intubation that you do. The catheter is stiff enough that it doesn't flop when you're putting it through the cords. It's small, so you don't have to deal with البوزيشن التوب كبيرة شوية ولا position ممكن مغير الانجل بتاع التراكيا. الحاجات اللي بتحصل مع الانتوبيشن دي ما بتحصل مع المست. So I would say probably easier than intubation.
Okay, thank you.
No, the big difference is the patient is not paralyzed. So
was the swaddling and the sucrose enough to soothe the baby a little?
You know what? That's a good question. So, in our experience, younger babies اللي هم 26 weekers to 32 weeks did very well with that. The older babies didn't. We're not using mist as much in the older babies. Above 33 and above, we're shying away from it لأن هم it seems to not be enough. فبيكونوا very irritable, ما they fight the laryngoscopy وكده. لكن الصغار شوية بالذات لأن الحاجة دي دايما بتحصل in the first few hours of age بيكونوا شوية knocked out anyways. تلفيهم sucrose, they usually do really well.
Then we face the same problem with those who are 30 to 32 weeks.
أيوة. لا I see the older kids. يعني إحنا لغاية 32 weeks we would do it. Above 32 weeks most of the
we
time
don't also for us also.
Perfect. طيب اتكلمنا تخيلي شوية عن ال outcome of death, the treatment effect difference between the different gestational ages. عايزة بس أشوف لو anyone had any other comments on that point. Is everyone satisfied that it could be that it's not due to the randomization? We can't say that it's due to the randomization عشان كان في differences between the groups to start with.
Right, they were يعني they must have confounded the results somehow. لأنه زي ما قلت males ولا being males did not receive steroids كلها can confound the results يعني in a good way.
صح بالضبط كده. فأنا I think إنه يعني it's something to think about and to be cautious about the younger babies and cautious in terms of يعني we need more studies in the younger babies. لكن في نفس الوقت we can't say إنه MIST causes more death in this group of patients عشان the groups were different. They were already at higher risk of death just because of the lack of steroids or multiplicity or the fact that they were boys, more boys. طب كويس. Is MIST feasible in your unit? So بالنسبة للناس اللي ما عندهم MIST أو ليسا هسي, is it feasible, do you think? I think we talked a little bit about training, لكن مثلا فيها أي حاجة, any other points to discuss?
I think it's very feasible. يعني once مثلا الحاجة الإكسترا حكون محتاجينها بس الكاثيتر. إذا ما عندك already الكاثيتر ده إنه بس تجيبه. لكن أفتكر إنه quite feasible. The more important stuff is how comfortable unit الشغال بها at least هنا ده في بالنسبة إنه to use the use of CPAP. لأنه CPAP is some units use high flow أكثر من CPAPs لكن لأنه CPAP محتاج a lot of nurse attention from the bedside يعني make sure the ceiling and حاجة دي which is much more work compared to units that are more used to using high flow.
That's a good point. لأنه حاجة ما فكرت فيها والله لأنه أنا يعني everything that we presented الليلة is MIST with CPAP. أنا ما شفت أي studies that looked at MIST with high flow. Does anyone know if there are any studies looking at MIST with high flow? No. أنا ما شفت حاجة. I didn't come across any MIST with high flow. I think it's mostly been MIST with CPAP. So we can't generalize to high flow. So it means that the team needs to be comfortable with CPAP first.
Sorry.
Okay. Dr. Dalal, did you think this result between MIST and Ensure might be related that babies with Ensure usually we remove CPAP during their intubation, but the people kept during MIST? This is decrease the de-recruitment happening that we just achieved by CPAP and decrease the desaturation event that happened. So if we need to compare Ensure while CPAP on with the catheter. Okay, thank you.
Thank you for the question. And I think you're right. I think when they in previous studies when they compared MIST with Ensure, these were the thoughts that the clinicians were coming up with. So يمكن maybe it's because you lose PEEP, it's because you intubate and ventilate, and we know it only takes 5 large tidal volume breaths to start the cascade of inflammation that results in BPD. So I think with Ensure, the fact that you're intubating and ventilating, and as you rightly said, you're probably losing PEEP, maybe de-recruiting your patient, you have to bag with higher pressures to reopen the lungs. All of that, it probably increases the risk of BPD in these patients, and maybe that explains the benefit of MIST. I don't know if that answers your question.
Thank you, Dr. Adela.
ممكن تعرف نفسك please؟
سألت سؤال يا عبد الله ولا أنا ما خد الصوت قطع كده؟ عبد الله؟
الو ايوه محمد، بس كنت اتمنى انه كل واحد يعني يعرف نفسه مكان وين شغال والاكسبيرينس بتاعته يعني.
ممكن أي إذا خليها في النهاية بعد ما دلال تنتهي، لأنه إحنا عملناها في الحلقة الأولى. كان بس خلي دلال تنتهي وبعد كده ممكن نعمل تعارف صغير في الختام.
طيب جميل. طيب يعني I think we also talked about this lack of pharmacological analgesics. كان في concern من الجروب وانا I share it. يعني تخيلي المشكلة أكبر في ال older babies إنه إحنا ما بندي pharmacological analgesics، لكن at the same time إنه يعني we have to make sure إنه the patient is spontaneously breathing ولا this procedure is not going to work. Any additional comments on that ولا questions?
No, أفتكر إنه no pharmacological is a very sound decision، لأنه once you start giving them morphine أفتكر ما حتقدر تدي بيهم muscle relaxant at all، لأنك you want them to continue to breathe. فإذا اديتهم sedations يعني respiratory drive حتقل، حتحتاج إنك تعمل either PPV أو احتمال تعمل intubation which negate الفكرة بتاعت أساسا إنك less invasive.
No, I agree. ويعني أمين معانا هناء ما معانا ليلى مش؟
أنا ليلى ما رجعت.
لكن maybe هناء يعني at some point you can talk to us about NITCAP لأنه I think that's where يعني developmental interventions ممكن تنفع، لأنه إحنا هنا خلاص we know إنه there's a lot of downsides of giving a narcotic in a procedure like this. فمعناتها the non-pharmacological measures of pain control are going to be more important. فأيوة عندنا السكروس والتاكينج patient وكده، لكن we know that doesn't work for all patients. فهنا في اليونت في Edmonton الNITCAP team is starting to join missed procedures when they can عشان to optimize the developmental environment للpatient و يعني to point out what works and what doesn't work for a specific patient to help calm them down during this procedure. طيب, is this generalizable to other types of surfactants? So I work in a unit where we have CuraSurf for studies mostly. لكن ما عندنا CuraSurf to use on our clinical babies. فحتى لما نعمل mist هسه في clinical baby we use bless most of the time. يعني unless for some reason كان في CuraSurf قرب يبوظ ولا حاجة زي دي ممكن نستعمله. الCuraSurf بالنسبة لنا في كندا أغلى من البلس. عشان كده our province doesn't pay for it, they only pay for bless. Can we generalize the results of this study to other types of surfactant?
How different is the mass to the CuraSurf? Sorry to interrupt.
What was the question, Yasari?
How different is the mass to the CuraSurf, just to be able to gauge? Is it larger volume or?
Exactly. So bless is 5 mils per kilo. CuraSurf is 2.5. So it doubles the volume for the same dose of phospholipids.
I think for sure units who use a lower volume surfactant are at an advantage. I use CuraSurf.
الحاجة الثانية أفتكر البلس is driven from bovine resources. CuraSurf is different. Okay, أفتكر. والحاجة الثانية أفتكر there was studies comparing البلس ل CuraSurf who didn't show any difference in terms of effectiveness. لكن طبعا ما كان فيه compared different type of surfactant to different type of administration. I think it's safe to make the point it shouldn't make any difference what type of surfactant to use, صح?
أنا تخيلي محمد the only problem I think is what Sally was referring to إنه CuraSurf was smaller volume. أنت هنا ما قاعد تعمل PPD. Potentially babies that get blessed through mist are more unstable than babies that get CuraSurf by mist. عشان you're putting in a larger volume without an ability to bag it. Not an ability, and you can still bag, of course. لكن usually you're not ventilating.
No positive pressure.
أيوة.
To sustain positive pressure.
فبس يعني it's CPAP لكن it's not PPV most of the time. So and I don't know, but anecdotally يعني من التيمز اللي شغاله في الأوبتيمست ترايل عندنا في السايت حقنا بيقولوا إنه هم they think in the babies that get CuraSurf are more stable than through MIST are more stable than babies that get BLESS. لكن personally I don't have any data to prove that. لكن it's just anecdotes.
طبعا هنا ما بنستخدم اصلا CuraSurf it's porcine. طبعا هنا عارفين الريستريكشنز religiously يعني speaking. لكن في الانفاسيرف وفي السيرفانتا اللي هم both either it's bovine lung lavage ولا minced bovine lungs وكده. I think it's when it comes to compare what type of surfactant is feasible for MIST or LISA or whatever, it's the two things, the volume and the viscosity. This is what you need. خلاص. most of the surfactants that are used هم the same except يعني مثلا Infasurf هو a little better لأنه 3 mils per kilo. مثلا إحنا بنستخدم السيرفانتا اللي هو calfactant it's 4 mil per kilo. فهم usually between 3 and 4 mil per kilo. ما عدا أنت قلت البلس 5 mil وعندكم الCuraSurf into 2.5 mil which is much less. فهي mainly الفوليوم والفيسكوسيتي determines which one is better يعني عشان بس التايم consumed في البروسيجر وكده.
أيوة. That's very good points. Thank you. And just يعني coming to the point that Wafa you were talking about أصلاً CuraSurf is porcine. that potentially can pose a problem للمسلم patients حقنا و Jewish patients حقنا.
كويس. أنا افتكرت كده.
يلا أنا داير أقول لك شنو إنه يعني أنا ما أعرف لو في زول مثلاً عنده فكرة عن يعني لو في أي فتاوي طلعت يعني إحنا عندنا family that was interested in the study وتكلموا مع الإمام حقهم وقال لهم عشان عندما يعني المهم قال لهم إنه it's fine it's okay they can get CuraSurf. فما عارفة لو فينا عندهم any more information about that. طبعا واضح إنه في السعودية أساساً ما لكن بالنسبة
other options ما حد.
I think it totally depends on يعني for me personally from a Muslim background, it will depend if there is another option, an alternative that will solve the problem. If it's the only option, then no, يعني ما حيكون في issue. Like if you're entering just يعني for the purpose of the study, is that justifiable? If there is another option that you can give, not sure.
I think these 2 points are kind of tied together. صح لأنه أنت if you can't generalize the results of the study to other types of surfactants, well, the other types of surfactants are not studied, then and you can't use CuraSurf, then maybe we can't generalize. So تخيلي 2 points there they tie together. طيب, what do we think about the exclusion of 25 and 24 weeks? Anyone less than 25 weeks? I meant. Sorry, this was a typo. Exclusion of infants less than 25 weeks.
أفتكر اسمه ده. أفتكر إنه يعني they missed a real good opportunity هنا إنه to include less than 25 weeks لأنه كان will make a big difference for them. Not to be intubated or even for insure or try them on CPAP. And even some units, they don't think of trying CPAP from the get-go and see how things, like 25 weeks, and they will go straight for intubation.
هو actually أنتوا عندكم مثلا from your experience, what is the percentage of those below 25 weeks who really make it on CPAP from the beginning to the end?
That's an excellent point. So إحنا بالنسبة لنا في اليونت حقتنا كان 23 weekers حقنا none of them were actually يعني none of them were never intubated. At 24 weeks there was this very small number. 25 weeks and above, a significant number of babies don't get intubated. Like in 24 weekers was a small number too. It was somewhere around 15%. فعشان كده إحنا مثلا بالنسبة لي أنا for my unit it's not a big deal that they didn't include the 24 and 23 weekers لأنه إحنا we're not good at keeping these kids extubated anyways. Yeah, so and some neonatologists, actually I shouldn't say some neonatologists, there's one team in our unit where we introduced a new BPD guideline where we intubate and give surfactant at birth to all babies born at 23, 22, and 24 weeks. So the micro preemies less than 25 weekers. So that's why we couldn't use the study on them anyways. لكن we haven't generalized that to all babies yet لأنه كنا عايزين نعمل soft rollout ونشوف الإفكت حقها شنو قبل ما to generalize it to all babies. As we all know إنه أصلاً I think it was only the support trial that included 24 weekers. I might even be wrong. Maybe it's the COIN trial. Like most trials did not include 24 weekers when it looked at prophylactic versus selective surfactant. So we don't know that selective surfactant is better in these small babies.
I think another point, يعني recruiting less than 24 weeks or less than 25 weeks is going to be really difficult. لأنه يعني already numbers بتاعتهم very low. All the premature babies من هو 35 or less كلهم كم 12% من التوتال birth. تيجي تشوف الناس اللي هم less than 25 weeks or less than 24 النمبر حيكون very صغير. I really doubt in any study can generate يعني a generalizable outcome.
Exactly. And I think
it's got to do with the ethics as well of it. So if you're in a unit that you know that your 24 weekers don't get to have only CPAP and not intubated, would you be able to consent for that from an ethical point of view, because you really do know that most of them don't survive on, like, continue on CPAP without needing intubation? Or does that not have a weight bearing on that?
I don't think the ethics of it would have been a problem لأنه if these babies met criteria for intubation as per the clinician anyways صح. لكن I think the problem is ما حيكون عندنا babies كتار. For us 0-23 weekers and only a few 24 weekers that are on CPAP. So the eligible patients for the study, the number would have been so small in our site.
You don't revive them 23 weekers in your center?
We do. Oh no, we do, but they all get intubated.
Yeah.
No, we go down to 22.
And maybe our percentage of إحنا 23 to 25 weeks maybe a little bigger. لأنه السعوديين هنا العرب ما شاء الله بولدوا كثير ما زي اليوروبيانز. يعني إحنا عندنا مثلا بيكون 1100 admissions per month عادي يعني مثلا.
Oh wow.
يعني أي عادي ممكن يكون عندنا كم per month يا ربي كده بكون أيوة لأنه at the end of the year عندنا 10,000 sorry per year I mean مش per month 1100 per year أيوة فبكون عندك 10,000 deliveries per year 10,000 per year يعني شوفي 10% of them they get admitted فبكون ال percentage of البيبيز هي compared to the general percentage is not big لكن the actual number is not a small one as well.
ولكن do you have 24 weekers that stay on CPAP and not need to be ventilated?
No. Usually anyone below 25 weeks يعني حتى below 26 weeks يعني كل almost 100% of them are intubated already. يعني ممكن 26 and above شوية يكون في a small percentage of them they make it on CPAP من labor ward.
And that's exactly what I meant. The number of babies that get away without intubation at that gestational age is very small.
Yeah.
Any other points? I think that was the end of it for me.
Thank you.
Thank you all. It was very nice discussion. Yeah, great to get to know you all.
شكرا دلال. Very interesting. Sorry.
Just one more thing. Sorry to
تفضلي.
What do people think about the PDA management? The reduction of management in PDA.
Well, it's a good point. I didn't put it there. And I don't have an explanation for it.
Exactly. أنا برضو كانت يعني it was astonishing to me يعني what is the relation إنه يعني why it was noted that إنه those on the was it just a coincidence يعني هم there was less PDA in those babies. It was just a coincidence. I don't think it's Lisa or
if it was surgical management, you could argue maybe kind of like exactly. It's like a bias effect of taking the baby out of the ventilator, and that's why people will go for less surgical management, but even medical management, which is very strange.
It was actually medical therapy and surgical. I mean, the study was large enough, I think, to detect a real difference. I don't think it was. It was statistically significant, so I don't think it was just a chance. صح؟ لأنه p-value was low. لكن I don't know. I don't have an explanation for it.
Physiologically, you cannot explain it. Why was it low?
I mean, the only possible explanation I can think of, مثلا إحنا personally, babies that are not ventilated were less likely to treat their PDA. So, I mean, that might be influence it. لأن إحنا عارفين إنه babies that were under the MIST group, they had less intubation overall, less intubation days, less ventilation days. So I wonder if people just ignored their PDA, didn't treat it.
أفتكر this is the major لأنه I don't think the trial standardized the approach to the PDA whether to treat or not. But we get up to the treating physician. وزي ما قلت انت there is a lot of many physicians will say if it's not causing any problem, if the baby is not intubated, why treat the ducts, while others prefer مثلا to treat the duct. It's very hard to make sense of a result and use it as a guarantee outcome مثلا لأن using MIST إنه you want less time to treat the duct. There could be other factors إنك تحتاج to treat the duct مثلا feeding intolerance بتاع حياة زي دي. لكن from a respiratory point of view, I don't think it is you can make sense out of it and result in a statistically significant. طيب إذا في زول ما عندي سؤال تاني أحب أشكر دلال على very interesting session. شكرا جزيلا. صحيناك بدري الليلة صح؟
يا محمد أنت نسيت التايم ديفرنس ولا شنو الساعة عندنا؟ 12:30.
لا سوري 8 ساعات سهرنا من السعودية. لكن في إنجلترا ما عندنا مشكلة. either way إحنا كويسة معنا. وhopefully just a quick info. The next session إن شاء الله حيكون يوم 26/3. Just let me check. I'm checking the right date. We already have a volunteer. أيوة يوم 26/3 الساعة 6:30. We already have a volunteer. أفتكر وفاء حتدينا some session أو paper عن ventilating babies with chronic lung disease. مش كده يا وفاء؟
عموما حنتكلم عنها وشويه الاستاديز اللي اتعملت عن شويه الموداليتيز بتاعت التريتمنت بتاعتها ونتناقش فيها ان شاء الله. طبعا it's a very big topic يعني لكن هحاول اختصر ان شاء الله.
خلاص فإن شاء الله يوم 26/3 we'll do the session.